Welcome. Greetings, everybody. This is GFR MD1, Dr. Abo coming at you with our GFR TXA CBT. We are going to talk about TXA, tranexamic acid, for the next 15 minutes or so please do bear with me. TXA is a monumental medication that we're finally adding, and this will be added immediately, and this is one of those low risk, high yield medications. So TXA, you've probably heard about the military using and us using in like Africa to save a lot of lives with postpartum hemorrhage and things like that. And you're wondering, like, is there much evidence to it? No, overall, there's pretty good evidence. And even, one of the first things that comes to mind, and obviously, for your sake, I'm not going to get too nerdy, but the CRASH 2 trial was pretty monumental. And this was a randomized controlled trial. And this was one of the first big ones more recently. And even with 20,000 patients, right, and they either got TXA or they got placebo, normal saline, and they did it differently. Like, they even looked at it was within 8 hours of injury, and they only did 1 gram IV and then a gram infusion over the next 8 hours. And they were looking at overall death within 4 weeks of injury. And even that, they saw that it reduced all-cause mortality, and they realized, you know what, especially within the first 3 hours of injury, if you give it, it reduced the risk of death because of bleeding. And of course, CRASH 2 isn't the first one. There are a lot of other studies too. And you've heard some debates about, it's not really doing much. This and that. Actually, even more recent ones, again, they said that, didn't really make a big difference in 6 months and this and that. Again, 1 gram and then 1 gram. But they still saw that it reduced deaths. So overall, low risk, high reward for TXA, for hemorrhagic shock. So this is, I've been using it with my other services for quite a bit. We had to get some others on board. And we're going to go over the tips of the medications and all. But again, it's going to be a 2 grams TXA. We're only doing it for adults for now, and that's a slow IV push. As written, and finally got, we're going to go through this all specifically, but this is all the different routes, and it's your medication page. And then as soon as it's made appropriate changes within the protocols for trauma care and all, it'll be in there. But this is something that immediately, once you do the CBT, is part of the arsenal, and you're expected to use it. Let's get into how TXA, and I don't really like it being that it stops bleeding, because it doesn't really stop bleeding, but
when a blood vessel is ruptured and starts bleeding, the body responds by forming long strands of a tough yellow protein called fibrin that traps blood cells and plugs the leak. This is called clotting. However, at the same time, it triggers another process, which is not always helpful. It begins with these playful canines called plasminogen, but they won't be playful for long. The torn blood vessel has released tissue plasminogen activator, or TPA as he likes to call himself, and he loves causing trouble. Once TPA shows up, the plasminogen dogs get nasty. These hounds of hell are plasmin. The plasmin dogs tear fibrin apart, making the bleeding much worse. Of course, plasminogen activator inhibitor 1, or PI1 for short, could put a stop to all this destruction if she wakes up. And when PI1 does wake up, it's often too late. That's why we give tranexamic acid as soon as possible after bleeding starts. Tranexamic acid stops plasminogen binding to fibrin, sparing the clot from the plasmin dogs. And a nice blood clot can stop the bleeding.
There you go. Any questions? Just kidding. All right. So basically, TXA is a natural part of the clotting cascade because hemostasis is everything. So we help make clots, right? And then the clots break down. We make clots, the clots break down. So what this is doing is it's not really stopping bleeding. It's helping stop the clot breakdown so that you don't start bleeding again. As you can see, and I have one more version that I made. It's not a procoagulant. It does not promote clotting. The goal is to stop the breakdown of the clot, right? So if you have some sort of injury, right, and it could be, capillary, but you have some sort of vascular injury, so you're bleeding, it sets off a bit of different cascade of different things. And we have stuff that makes the platelets, which is the clump, right? And then the fibrin is the net that holds that clump together. So boom, we stop the bleeding, yay! But fairly soon we start actually breaking down that clot so we can start replacing scar tissue, different things, right? And so that's where on the right side you see the blood clot with plasminogen that activates plasmin, and it's the plasmin that breaks down the clot for fibrinolysis, right? So this is like what we do with stroke care, right, where we're giving TPA. Well, the opposite of TPA is TXA, so that's TXA stops that breakdown. It stops the plasminogen from going to plasmin, right? So where can we use this? Overall, the evidence shows, the indications are within 3 hours of injury, moderate to severe exsanguination. So exsanguination, of course, is when you're bleeding to death. So that can be bleeding out. Outside your head, you're bleeding in the chest, you're bleeding into your abdomen, the pelvis, into your femurs, into the street, and so that's gonna be a 2-gram IV push. Right? You're just not slamming like adenosine; it's just over 30 seconds or so. So major trauma, polysystem trauma, yes, 2 grams. Postpartum hemorrhage, yes. GI bleeds, meh. Right now the data is not really there, so we're not going to indicate that. Major epistaxis, nosebleeds, yes, and you can also give it intranasal with the MAD device, and you can also nebulize it. Post-tonsillectomy, I saved a 25-year-old paramedic friend of mine who's exsanguinating to death, and she was admitted to the hospital. They didn't know what to do, and I happened to be visiting, and she's just, it was like The Exorcist with all the blood, and I just jumped in, took care of it. She got 2 grams IV. She got, and then I sprayed in the back of the mouth, and it helped a lot, right? Hemoptysis, severe, yes. You could even give it basically mucosally topically. And how would you give it topically? You can't shove your fist down someone's throat, so you can go ahead and nebulize it. Bleeding inside your skull, like a subarachnoid hemorrhage, intracranial hemorrhage, no. Because you're not bleeding out to death, that's a pressure issue. So if you're bleeding out and you're exsanguinating, bleeding out to death, hemorrhagic stroke, hemorrhagic, let me correct myself, hemorrhagic shock, that's it. right? And that's going to be within 3 hours. Now you might say, but doc, she's had bleeding, vaginal bleeding for 2 days after delivery. But in the past hour, she suddenly had pain and she's been massively bleeding this past hour. Yes, absolutely give it. So let's go through our medication indication page, right? So polysystem trauma alerts within 3 hours of injury. It says significant active hemorrhage. Um, even if the bleeding stopped, you should still be giving this. For instance, what if they just don't have enough blood to bleed anymore? So we're going to fix some wording on this. I have to have some discussions. However, so polysystem trauma alerts, again, within 3 hours of injury. Postpartum hemorrhage, again, within 3 hours of that severe bleeding. You can give it topically mucosally or mucosally topical, however you want to put it. So, they have tooth bleeds, stuff like that. I just don't want you, when it's written as topical, it's not supposed to be like quick clot where you have bleeding on the skin, things like that. This is for the mucosa where you can put pressure, like after dental surgery, or essentially you're giving it mucosally topically by nebulizing it, bad nosebleeds, things like that. An example of nebulized is massive hemoptysis. Note that there are no contraindications. It's just simply not indicated for 15 years old, right? The cautions that are listed here, right now for Alachua County, it's not indicated for pediatrics to the trauma centers, right? GI bleeds, not appropriate. Intracranial bleeding, not appropriate. And if it's minor, then don't worry about it, right? Pregnancy category C, that means we treat the mom and it's okay. You're only going to see that hypotension if it's rapid push like adenosine. And do know that, there were some thoughts, but it's actually been recently disproven about the increased risk of thromboembolism by giving it IV. That's only if you have really a history of those, and I'm not worried about it at all. Technically, it's not 0%, but more and more studies show that there is no actual increased risk. So again, the dose is 2 grams slow IV push or IL, and you're going to go ahead and also nebulize a gram if you want, or you can spray it. I do not agree with this being recommended. I prefer it to be IV push. ACFR is going to have their recommended, in a little drip. The reason I don't really like that is because it's never going to go in. Who's going to stand there with a polysystem trauma, hold up this little IV bag, especially when we have a shortage, and let it drip in, right? So we're going to put it down, lay it down, and then it's never actually flowing in. So again, there are no contraindications for TXA. It's just that it's indicated only for adult patients for exsanguination within 3 hours. And we will work on the area getting more of the time so we get the pediatric dosing as well, right? Please remember, with things, as you are doing your proper documentation, right? So an example of writing a narrative for a patient where we've used TXA would be something like Engine 3, District 1, rescue whatever, dispatched, multiple GSW. Chief complaint, multiple GSWs, I'm bleeding, quote unquote. History, this is your history of present illness. We already did kind of the past medical history, surgical history. So 34-year-old female, shot multiple times throughout the thorax, approximately 20 minutes prior to arrival. No pre-arrival instructions given, no care except for tourniquet placed by LEO on the left leg. Assessment: multiple GSWs to the thorax, one to the leg with a tourniquet in place, properly in place. Treatment: bleeding control, IV pain control. Assessments: 2 grams TXA, or just write TXA because we already put in the flow chart that you guys are using, right? Thank you. Transported emergently to the trauma centers, a level 1 trauma, exceptions none. All right. Any questions? Anyone? No? All right. GFR MD1 out. Love and respect you guys. Let me know if you have any questions. I will say this for one other add-on. I do want every unit is going to be carrying 3 grams so that you can give it IV and also give a nebulizer or anything if you need that other gram. Thank you very much.